Okay, I'll take that as a gentle nudge to get going. So, so good morning. Sorry, good afternoon, everyone. So welcome to the New England sleep seminar that's developed here across multiple institutions, anchored at Yale, but also with participants from Tufts and Brigham and BMC and BI and Children's and MGH, really quite the collaborative effort here. My name is Eric Heckman. I'm filling the shoes of Andrzej Zinczek today, who's out of town. And so I'd like to make a few brief housekeeping announcements before we get going. Please take a moment to make sure that you're muted for the presentation. In order to receive CME credit for attendance, please see the chat room for instructions that will be posted in the minutes after we get started, with instructions to claim that credit via text. If you have questions or comments during the presentation, please use the chat room during the presentation itself, or you can take the opportunity to unmute yourself at the end of the talk and ask those questions. And we'll make sure we have some time for those. So with that in mind, allow me to introduce Tom Scammell, who's our speaker joining us today. Dr. Scammell is faculty at Beth Israel Deaconess Medical Center, and he's done his undergraduate studies at University of Rochester and his medical school training at University of Massachusetts Medical School. Went on to residency training in neurology in a combination of UMass and University of California, San Francisco, before coming back to the then Beth Israel Hospital for a research fellowship, and later clinical fellowship in sleep medicine at the then BIDMC. Since then, he has remained on faculty at BIDMC and risen through the ranks to attain the status of professor of neurology at Harvard Medical School. And throughout his career, he has a consistent footprint in basic science, looking at the neurobiology of narcolepsy, and has an impressive track record of steady funding to maintain a lab in that regard. He has become a respected international speaker on the topics of narcolepsy, and has been a mentor for many, both in the research realm and a steady presence in clinical training. I can attest to his ongoing and persistent involvement with the training of the sleep fellowship, the sleep fellows. He's also had a heavy presence and transitional implications for management of narcolepsy, being heavily involved in patient advocacy groups for narcolepsy, as well as involved in as a consultant for target identification and development for many of the pharmaceutical companies you can think of that have had interest in this area. So I think you'll agree that background gives him excellent experience to talk on what he's going to be discussing today. So Tom, thank you so much for joining us.
Great. Thanks so much, Eric. All right, I'm just going to share my screen here. All right, does that look okay? Yep. All right. So I was asked to speak about orexin agonists, and there's not a lot of public info on this yet. So my talk is kind of covering a few different things here. We're gonna just first, as Eric said, I consult with pretty much all the companies in the narcolepsy space, including some of those that are making orexin agonists, which is the topic of this talk. And if you want to get CME credit, there's the text thing down there below, and you can do that during or up to 30 minutes after this talk. So what I'm going to talk about is just briefly run through the current meds for narcolepsy, just to kind of sort of set the stage and why we need newer and better meds. I'll provide some of the rationale for why it makes sense to develop orexin agonists. And then I'll show you some of the data, which is really fun, on the basic research that's been done in this and the small amount of clinical research. These drugs are still a couple of years away from actually reaching clinic, but I think you'll see that there's reasons for some pretty good enthusiasm. So I think that this hardly needs to be mentioned, but I'll just quickly say, you know, the major symptoms of narcolepsy, of course, are daytime sleepiness. Everybody's got some degree of that. And in narcolepsy type 1, which is narcolepsy with cataplexy, the patients, of course, have cataplexy which are these emotionally triggered episodes of muscle weakness. And that's really a symptom of probably the paralysis of REM sleep that's somehow mixing into wakefulness. And that whole idea of REM mixing in with wake is a feature of narcolepsy. And so they can have sleep paralysis and hallucinations. And they can also have fragmented sleep, which probably is kind of a testament to the fact that just in the same way that the thresholds, the boundaries between wake and REM are weak, the boundaries between non-REM and wake are weak. And so it's easy for patients to fall into non-REM, and it's easy for them to wake up out of it. And so they have very fragmented states in general. And they also have a higher prevalence of other sleep disorders like obstructive sleep apnea, central sleep apnea, periodic limb movements, REM behavior disorder, non-REM parasomnias. The REM behavior disorder is particularly interesting because it's sort of the opposite of cataplexy, right? You know, in cataplexy, you're seeing the atonia of REM coming into wake. And with RBD, the atonia is failing during REM sleep, and yet about 30% of narcolepsy type 1 patients have some dream enactment. The good news is it doesn't carry any concerns about a synucleinopathy. You know, a 20-year-old with RBD probably has narcolepsy, and there's no concern about them ultimately developing some sort of Parkinsonism. People with narcolepsy are also prone towards putting on weight. It's particularly dramatic when it starts in kids, and they're also more likely to have depression. So the current medicines, I think, are familiar to most of this audience. And here's a list of the meds that we currently use for sleepiness. Stimulants, modafinil and armodafinil, which I consider pretty much interchangeable, solriamfetol, pitolisant, and the oxybates. And I'm going to spend a little bit more time on the bottom three of these because they're new, and I think it's possible that some of you haven't had much clinical experience with them yet. I've listed some of the major side effects, and I'm not going to really dwell on those particularly. But I also want to just highlight the cost over on the right-hand side because these meds vary in cost from a few $100s a year to $175,000 a year. And so that's certainly the economics is something you also may want to consider when picking your meds. So amphetamines have been used in the treatment of narcolepsy since the 1940s, and they work primarily by blocking the reuptake of dopamine. So on the left here, you can see a typical dopamine nerve terminal. The dopamine molecules are the little black dots. And normally, once there's an action potential, the dopamine gets released. It has some effect on postsynaptic receptors, which wakes you up. And then that dopamine gets taken back into the nerve terminal by the dopamine reuptake transporter. And so the primary effect of amphetamines is to block that reuptake. With moderate to higher doses, they also block the packaging of dopamine into the synaptic vesicles. So they interfere with the vesicular monoamine transporter. And the cytoplasmic concentrations of dopamine can get to be so high when you foul up that packaging that the dopamine can literally flow backwards out the transporter. And so you can get an efflux. And so that's why really high doses of amphetamines can actually give you a big rush of dopamine as well. With very high doses, they can also interfere with monoamine oxidase and slow down the metabolism of dopamine. But the primary effect, like on a board question, would be blockade of reuptake. Amphetamines also work to a lesser degree at the norepinephrine and serotonin transporters, having very similar effects, but most of the wake-promoting effect is mediated by increasing dopamine tone. Modafinil and armodafinil are pretty much interchangeable. Modafinil is the racemic mixture of the R and S enantiomers, and armodafinil is just the purified R enantiomer. These also block the reuptake of dopamine. If you give them to mice that lack that dopamine transporter, it doesn't do anything. It's pretty impressive. And, you know, of course, these are nice meds, probably, you know, overall less potent than high-dose amphetamines, but still pretty solid and nicely tolerated with a pretty low side effect profile. The one sort of dreaded side effect is Stevens-Johnson syndrome, but it's only seen in like 1 in 10,000 people. So let's go a little bit more slowly now on some of these newer ones. So solriamfetol, brand name is Sunosi. This is a combined dopamine and norepinephrine reuptake inhibitor. The package says don't use it with a monoamine oxidase inhibitor, but people hardly use those at all anymore. You can see the structure of solriamfetol here on the left. It looks a lot like the monoamines themselves. It's got nice pharmacokinetics, and so you can see the fasted and fed PK curves on the right-hand side here. It basically lasts all day. And so it's really a nice med for once-a-day dosing. It's got a half-life of 7 hours. You know, in contrast to modafinil, where people sometimes have to take modafinil twice a day, solriamfetol really seems to work pretty reliably as a once-a-day med. However, as you can imagine, with the longer half-life, its Cmax is a little delayed at 2 hours. And so, if somebody needs something that's really going to get them going quickly in the morning so they can drive safely to work, the solriamfetol alone might not be sufficient. The drug was initially studied at doses up to 300 milligrams. And so here you can see from one of the clinical trials, maintenance of wakefulness test results with placebo in white, 75 milligrams in yellow, 150 milligrams in the purpley color, and blue is the 300 milligrams. The 300 milligram dose was not approved by the FDA. They felt that the cardiovascular side effects were too high to warrant its approval. And so 150 is the max dose. But nevertheless, it's kind of nice to show this slide because it shows this really nice dose-dependent improvement in the maintenance of wakefulness test. And so this is a combination of patients with narcolepsy type 1 and type 2, and at baseline, their maintenance of wakefulness test latency was 7.5 minutes. And so, they're instructed to try to stay awake for the entire 40-minute test period, and they're falling asleep in 7 or 8 minutes. And this is showing the change from that baseline. And so with the placebo, they're 1 or 2 minutes better over the course of this 12-week trial, about 4 to 5 minutes with the low dose, and 9 to 10 minutes with the 150 milligram dose. That's a pretty good improvement. That's very respectable amongst all the wake-promoting drugs. And you can see on the right the reductions in Epworth scores with reductions of 4, 5, or 6 or 7 minutes with the higher doses. Nice side effect profile. It's kind of similar to modafinil, headaches, nausea, a little bit of decreased appetite, which you might expect from the norepi aspect. You do have to watch blood pressure. It's not a huge effect, but still, honestly, with all wake-promoting medicines, you should be checking blood pressure in your patients routinely. It's a small effect, but as I said, with the higher doses, you can start to see like about a 5 millimeter increase, and that was more than the FDA was willing to tolerate. As you can imagine from drugs that bump up dopamine and norepi, you can get psych stuff too with anxiety, psychosis, and mania. It's Schedule 4, and it's approved, of course, not only for narcolepsy, but for residual sleepiness and sleep apnea if a patient's not adequately alert with their CPAP. All right, pitolisant takes a bit of explanation. This is brand name Wakix, and this is a histamine H3 inverse agonist. And so histamine is another wake-promoting chemical. It's released from nerve terminals, just like I showed you with the dopamine, acts on histamine H1 receptors to wake you up. And the H3 receptor is a inhibitory presynaptic receptor. So it's expressed on histamine nerve terminals. And when histamine tone gets to a certain level, it inhibits these nerve terminals, preventing the further release of histamine. So it's auto-inhibitory. What pitolisant does is it blocks this. And so it's kind of an antagonist of this H3 receptor, but technically it's an inverse agonist because the receptor is constitutively active. And so basically what happens with pitolisant is you're no longer getting this negative feedback, and that allows the nerve terminals to release more histamine. And so pitolisant increases histamine tone. The H3 receptors, however, are also found on other monoamine nerve terminals, for instance, the ones that release norepinephrine, dopamine, and also non-monoamines like the acetylcholineurons. And so when people have done microdialysis to actually measure the levels of these neurotransmitters in the brain, with pitolisant, you actually see increases in all of these. And so it's kind of cool in the sense that pitolisant increases a whole variety of wake-promoting neurotransmitters. One rationale for it is that there was a paper from Seiji Nishino showing that histamine levels are possibly low in narcolepsy, as well as idiopathic hypersomnia. But that's also been contested. Yves Dauvier had a paper where he disagreed with that. Nevertheless, on theoretical grounds, that idea of bumping up all these monoamines and acetylcholine sounds like a good approach for improving alertness. This is showing the clinical effects from the phase 3 studies. And so what you can see in the placebo group is that these patients, this again is another mixed group of type 1 and type 2 narcoleptics. Epworth scores start rather high, 19 at baseline, and then 16 in the placebo group. And with pitolisant, the Epworth went down to 12, which is good. And the maintenance of wakefulness test results, the pitolisant group's going from a sleep latency of just 7 minutes, improving up to a little, almost 10 minutes. The SART is an alertness test. It's kind of like the PVT. And you see some improvements on that as well. Here you can see on the right, you can see the changes in Epworth score over time. And what this shows is that the improvements in Epworth are pretty comparable between pitolisant and modafinil. You see a placebo response in the blue group, and the reductions in Epworth are pretty similar between those other two meds. Pitolisant also has the advantage of having a nice long half-life. In fact, it's such a long half-life of 20 hours that sometimes it's uncommon, but some patients actually have difficulty initiating sleep. And again, like with solriamfetol, it's got a rather delayed Cmax. It takes 3.5 hours to reach its peak, but because of the long half-life, the trough, it builds up over the course of days. And so you want to talk to people about it. Are they alert enough to drive safely in the morning? But it may not be a concern because there's going to be some carryover from prior days. It does have a CYP interaction, the CYP2D6. And so you got to use lower doses with certain antidepressants, and it can interfere with birth control pills like modafinil. It also can lengthen the QT interval, so it's important to check an EKG once somebody gets on a stable dose of this. It goes with a special prescription form, but it's not a controlled substance. So this, pitolisant, not only does it improve alertness, as I showed you just there, but it also improves cataplexy too. And that's probably because you increase monoamines, you tend to reduce cataplexy. And so this is a nice analysis because they broke apart generalized cataplexy and partial cataplexy. So the generalized episodes are those ones where people slump into a chair or fall to the ground, whereas partial may only affect the face and neck. And so over time, you see some reductions here. So it's along with the oxybates, it's one of the few medicines that's approved both for the management of cataplexy and sleepiness. So that's a good transition towards cataplexy meds. And we use antidepressants a lot. I particularly like venlafaxine, but fluoxetine really works well too. And pretty much any med that increases serotonin and to a lesser degree norepi is helpful for suppressing cataplexy. People hardly use tricyclics anymore, but clomipramine does work. It's just the anticholinergic aspects are kind of hard to tolerate. Anyway, nice thing about the antidepressants, they generally work quite well. You can get a good 80% reduction in cataplexy, and they're cheap. Pitolisant, as I just showed you, can work. And oxybates can also be very effective with 80% reductions in cataplexy. But both pitolisant and oxybates are pretty expensive. So we started a little late. And so I'm actually going to just skip over these. And I don't want to talk about the basic stuff, but just there's now 3 different types of oxybates that are out there. There's the one that's been around for 20 years, the old Xyrem, and there's a new generic version of it, but same drug, in fact, made by the same company. It's just got a generic label on the bottle. And this is what you could call the high salt oxybate. If you're giving a full dose of oxybate, you might be giving 4.5 grams twice a night, so 9 grams in total per night. That's got 1.64 grams of sodium in it, which is essentially doubling the amount of sodium intake that somebody should be eating each day. Your total dietary sodium is supposed to be like between 1.5 and 2.3 grams a day. So that's a lot of sodium. And that was really the rationale for this low salt version, where they have to put some kind of cation in to get it into solution. But Xywav, which has now been out for several years, has a mixture of different cations. It's got about 1/10 as much sodium as the regular version, but they use other cations. And so if you're worried about sodium, like if you have a narcolepsy patient with hypertension or heart failure or something, you really, really want to think about Xywav instead. But also just for kind of kidney health, maybe worth considering. There's no generic version, but my understanding is that the generic isn't a heck of a lot cheaper anyway. So I think it's really just based on your medical judgment rather than economic reasons of whether you want to go with the high salt or low salt. Both of these are given twice a night, but there's this new one that just came out about a year ago, which is a once nightly oxybate where they package the active oxybate in a timed release form. And so there's an immediate release and a slow release. And so you end up with a sort of a smeared out peak. The total area under the curve is pretty similar. So if you're converting somebody from, say, 9 grams of Xyrem, they would go on to 9 grams of Lumryz. And the efficacy and safety seem pretty similar. The thing that's different is the conventional oxybates, the Xyrem, Xywav, and generic are liquid. The Lumryz comes as this powder. And And so it comes in these fixed dose packages of 4.5, 6, 7.5, or 9 grams. And so you're kind of locked into specific doses. And so I think Lumryz is a nice option if you have somebody who really is having trouble with the twice a night dosing, or you should be worried about sort of safety issues in that regard. Like maybe they get mixed up and take too much on the second dose. And some people just like it for the convenience aspect. But I think, for some people who have been prescribing oxybates for a while, you get patients that land on intermediate doses, or you do weird dosing where instead of giving it just twice a night, you're giving it 3 times a night. For instance, I have some patients who have a total dose of 9 grams, but it's really 3 grams 3 times a night. So you don't have that dosing flexibility with the Lumryz. So anyway, it's got each one of these has its own specific appeal. So I'm seeing a couple of things in chat, but I think I'm going to save questions till the end. So actually the things on the right just summarize what I just had talked about. This shows the pharmacokinetic differences between these. So in the gray is the conventional oxybate, where you're giving the 2 doses, in this case, separated 4 hours apart, and you get these 2 Cmax peaks. The once nightly is the blue curve, and the total area under the curve is pretty comparable. Okay. So this is from a very old meta-analysis done by Merrill Mittler, where he was showing how patients, if you get people titrated onto a peak dose of modafinil, methylphenidate, et cetera, how does their performance on the MSLT or the MWT perform to their baseline, compared to their baseline? And what you can see here is that they're better, but that dashed line up top is considered 100% of a normal sleep latency on these tests. And what you can see is that people aren't fully alert. And even the data that I just shared with you shows that, you get 5-minute, 10-minute improvements on MWT or something like that, but it's not getting them up to the normal range. And so, of course, even on really good optimal treatment where you've been very thoughtful about it, it's really hard to get a patient feeling really normal. And I think inspired by that, there's a really aggressive search for new and better ways of treating narcolepsy. And similarly, from a patient perspective, there's a lot of stuff that's still bugging them. This is a nice paper from Kieran Maskey a few years ago, where they did a big survey of people with type 1 and type 2 narcolepsy and asked what's really interfering with your day-to-day life and interfering with your activities. And you can see the things that you might expect: excessive daytime sleepiness and cataplexy. Disrupted nighttime sleep ranks rather high on the list. And the cognitive stuff is something that many people really are bothered by, where they say, well, I'm awake, but I just feel a lot of brain fog. I just still can't focus like I think I should. And so point is, there's still substantial room for improvement. So here's a list of the meds that I'm aware of that are under clinical or preclinical development. And there's several orexin agonists that I'm going to talk about. And I'll explain the rationale for those. You might have heard some of the Emory crew, David Rye, Lynn Trotty, talking about chlorothromycin. They have an interesting idea that they're potentially, particularly in idiopathic hypersomnia, but maybe in narcolepsy as well, there may be some weird endogenous chemical that kind of mimics sort of a benzodiazepine-like effect, and so blocking GABA A signaling could be helpful. And they're still continuing to do work on those ideas. Suvin is making another H3 inverse agonist. I don't know how that's going to be different than pitolisant. And then there's a couple very novel mechanisms of action, but they're in pretty early preclinical development. And so I think I'm not going to talk about those in detail, but there are other ways of waking animals up that might ultimately translate into interesting human therapies. Okay, so let's switch gears now and talk about the whole orexin story. So the orexins are neuropeptide neurotransmitters, a little bit like some of the pituitary peptides. And so, so you have this preproorexin messenger RNA that codes for orexin A and orexin B. Those are also known as hypocretin 1 and 2. I'm going to call them orexins because that we work with orexin antagonists, and now there's orexin agonists, and I think that's just going to become the language of the future. The orexins bind to the 2 orexin receptors, OX1 and OX2. And you're going to see that almost everything that I'm going to talk about subsequently is really focused on signaling through the orexin 2 receptor. These are both excitatory receptors. They have very similar effects on postsynaptic neurons, but they seem to do different things functionally. So mice that lack the orexin 2 receptor are pretty sleepy, and they have some cataplexy. Mice that lack the orexin 1 receptor are pretty normal. They have almost no sleep phenotype, and it really sort of makes one think that at least when it comes to the sleep relevant aspects of orexin signaling, the OX2 may be really much more important than the OX1. We can talk about the OX1 at the end if folks are interested, but most of the drug development stuff is really focused on OX2. The orexin neurons sit only in one place in the whole body, as best we're aware, and this is in the lateral hypothalamus. And so that's a coronal section of a mouse brain. This little slit in the middle is the third ventricle, and those are the orexin neurons. And here you can see them on the sagittal section with the orexin neurons just sitting in the hypothalamus there. So the orexins have very strong excitatory effects on all the wake-promoting brain regions. This slide is a little bit dense, but basically it shows the orexins excite the cells making histamine, the cells making 5-HT, which is serotonin and norepinephrine. And they also, indirectly, by activating those cells, they inhibit the neurons that are involved in generating REM sleep. So the green cells are all wake promoting. The blue cells are, to varying degrees, REM sleep promoting. And so when you increase histamine, norepinephrine, serotonin, you also suppress REM. And so if you squirt orexin peptides into the brain of an animal, you'll get about 4 hours of wakefulness and about 6 hours of no REM sleep. So it's this two-part thing: increased wakefulness, reduced REM sleep. Orexin tone is high during wakefulness. And so the best data that we have on this is not from humans, but from monkeys. Because of the temporal resolution, when you collect CSF in the lumbar space, it's not really reflecting well what's going on in the brain. And so there's really nice data that Jamie Zeitzer generated many years ago where he measured orexin levels using radioimmunoassay. That's the top thing. And he showed that, these monkeys have the same sleep patterns as humans do. They sleep during the dark. So orexin levels rise across the day and they fall during the sleep period. Just last year, a group came up with a mass spectroscopy a method to measure orexin, because it turns out that when you use the standard radioimmunoassay, like the orexin assay that's offered by Mayo Labs, 90% of what you're measuring with those antibodies is actually breakdown products. It's not the intact orexin. The mass spectroscopy measures intact orexin peptide. And what you can see is still the same general pattern, but it's got a little better temporal resolution because you're measuring only the intact peptide. And so again, if you measure from cisterna magna, cerebrospinal fluid, so close to the brain, you see this nice rise across the light period and a very sharp fall at dark onset as the monkey goes to sleep. One thing I want to emphasize is that orexin tone does not go to 0 during the night. You always have some orexin signaling, but it rises across the day and it falls during sleep. On the right is recordings of orexin neurons. And so one can put a fluorescent sensor into the orexin neurons specifically and measure their activity. And so up top, you see a very compressed EEG and EMG trace. And so the colors are indicating the different states. And so non-REM is this high amplitude stuff. You can't see the slow waves, but there's slow waves tucked in there. The orange is wakefulness. And what you can see is that the fluorescence is measured with this GCAM, rises during wakefulness. Every time a mouse wakes up, the activity, the orexin neurons rises. And so this is a method that has very nice temporal resolution. It doesn't measure orexin peptide levels, but it is measuring the firing rates, more or less, of the orexin neurons. And so you can see that they're wake active, and that undoubtedly contributes to why orexin tone rises across the day. And of course, the big thing from now more than 20 years ago is the discovery that narcolepsy is due to a loss of orexin signaling. And so in normal healthy controls, you see orexin levels around 320 picograms per mil, but there's quite a large variation, and there's some interesting physiologic differences between these people with high natural orexin and lowish, but still in the normal range. But in people who have narcolepsy with cataplexy, so type 1 narcolepsy, you can't see it, but there's all these dots clumped together down here, which is basically undetectable orexin. And so 90% of the time they have levels less than 110 picograms per mil. But the narcolepsy without cataplexy patients have normal levels much of the time. There's a smattering that are low, and many of those low patients will transition to narcolepsy. They'll develop cataplexy later. They just haven't shown it at the time that you interviewed them here. But anyway, of course, this now makes us think that there's these two diseases, phenotypically similar, but one is due to orexin deficiency, the other isn't. And in narcolepsy type 1, the orexin neurons are gone. And so on the left, you can see the normal pattern of orexin neurons in a healthy human's hypothalamus. And on the right, you can see that same level from somebody with narcolepsy type 1. There's typically a 90+% loss of the orexin neurons. And we're pretty sure the cells are dead and gone, because when you look at other things that are produced by the orexin neurons, other markers of those cells like dynorphin or something called NARP, that's also gone. There was a paper last year from the Tafti lab that's mentioned at the bottom references there, where they think that perhaps orexin production is just simply silenced through some epigenetic process. But I don't think that's likely. It's sort of a longish argument. And of course, the consequence of losing this orexin tone is that you have horrible changes in sleep regulation. So up top is a 24-hour hypnogram from a healthy control, where REM sleep is shown in the purple color. And in the bottom is a untreated patient with narcolepsy who's having fragmented sleep at night, multiple naps during the day, and REM sleep at all times of the day. And so this hypnogram just really nicely captures the sort of chaos that occurs when the orexin system is lost. And so overall, we have these monoamines that promote wakefulness. There's these ventrolateral preoptic neurons that promote sleep. And the orexin neurons have just this really important role on providing probably sustained excitatory tone on the waking side of this circuit that helps keep you awake all day. All right, so now to the meat of the talk here. So since orexin deficiency was identified over 20 years ago, I think everybody's like, oh, we got to make orexin agonists. And I remember talking to big drug companies a long time ago, and I said, hey guys, you got to start working on this. And like, ugh, so hard, we can't do it. They say, we can make drugs that block the orexin receptors. That's not so hard. That's just like jamming the wrong key into a lock. But making a key that truly fits that receptor, a small molecule, that's really hard. And yet they've made really great progress in the last few years. And part of this is a consequence of cloning the orexin receptors, finding their crystal structure, figuring out their shape, screening a bunch of ligands. And as you'll see, there's now a bunch of companies who are working on orexin agonists. It's a very busy field at the moment. And so, the appeal of an orexin agonist is that it's really targeting this fundamental orexin deficiency in narcolepsy type 1. And so the belief is that if you can replace that orexin tone, they should be quite effective. And even though narcolepsy type 2 and idiopathic hypersomnia patients are not orexin deficient, they're still sleepy. And so in the same way that we give amphetamines to improve alertness, it's possible that an orexin agonist may have benefits and potentially advantages in treating these other disorders of sleepiness. And I didn't really touch on this, but there actually are other neurologic disorders where they don't have such a severe loss of orexin tone, but they have some partial reduction. And so, for instance, if you look at patients with severe Alzheimer's disease, Parkinson's, and traumatic brain injury, you can see actually at least moderate drops in the number of orexin-producing neurons. And certainly, we've all seen Parkinson patients and TBI patients with problematic sleepiness. And so, it's conceivable that in these other sort of diseases where there's at least some orexin deficiency, an orexin agonist could be useful. And there's actually others like myotonic dystrophy, Prader-Willi syndrome. Those are also felt to have some degree of orexin deficiency, partial. And so the appeal is that, if you're working with a narcolepsy type 1 patient who's orexin deficient, and if you can just get the right dose of an orexin agonist, you might be able to actually get them to some normal orexin tone. And if you really thread the needle properly, maybe there would be very minimal side effects because you're just trying to get them back to a normal state. And so, as I mentioned, there's about half a dozen companies now working on this. So these drugs were first developed about 6 or 7 years ago, and the initial ones were not ever really suitable for clinical use, but they're still kind of cool. And so this was a drug called YNT-185 made by the Yanagisawa lab. And you might recall that Masashi Yanagisawa was one of the people who discovered the orexins and has worked in that field for a long time since. And it's nice to see him looking at the therapeutic stuff here. And so these are essentially hypnograms from mice. This is orexin knockout mice. And cataplexy in orexin knockout mice looks like an abrupt transition from wake to REM sleep. And so these little red things where I put a few arrowheads on, those are essentially episodes of cataplexy. And so here's a mouse in the dark period where there's some wakefulness that's disrupted periodically by cataplexy. And then if you give them vehicle, that doesn't change the behavior at all. They continue to have cataplexy. They continue to lapse into sleep. But if you give it an injection, and so this is given into the lateral ventricle because this drug doesn't cross the blood-brain barrier, the mouse just stays continuously awake and has no cataplexy at all, which is super impressive. And it shows that this general concept can work. Here they're calling cataplexy it's really confusing. In the animal research, they sometimes call them SOREMs, but these honestly are just episodes of cataplexy. And so an orexin knockout mouse has this dose-dependent decrease in cataplexy. But if you give the same drug to a mouse that lacks both orexin receptors, they have cataplexy because the orexin can't signal through the receptors, but the drug can't do anything because it's dependent on signaling through the OX2. This is a much more clinically viable drug. This is called danuvorexton from Takeda. It's also called TAK-925. This is a very good orexin 2 receptor agonist. The one downside with it is it's got to be given intravenously. But let me talk you through this because it actually, again, also shows the potential of this whole class of drugs. So here's the structure. If you look at cultured cells that express the OX1, if you expose them to orexin A, you see an increase in this calcium mobilization. If you expose them to orexin B, you see an increase. But if you expose them to TAK-925, nothing happens. But if you do the same thing now with TAK-925, you can see this green line, which is only about a couple log units shifted to the right of the native orexin peptides. And so what this shows is showing that this TAK-925 nicely activates the OX2 in cultured cells. If you give this drug to wild-type mice, you see a dose-dependent increase in the amount of wakefulness. But if you give it to mice that lack the orexin 2 receptor, nothing happens, even at a dose that's much higher than what you'd use in the wild type. So it's clearly having its wake-promoting effect through the OX2 receptor. Rebecca Evans from Takeda had a nice paper a couple of years ago showing a small study of just 13 patients with NT1 and a similar number with NT2, where she did the maintenance of wakefulness test. And so remember, this drug is given intravenously. And so what they do is they essentially give people an 8 or 9 hour infusion of this drug across the day. And so they get placebo in gray, a low dose of danuvorexton, 11 milligrams in red, or the higher dose, 44 milligrams in blue. So the placebo, so it's a crossover study too. And so when people are treated with placebo, they have super short latencies on the maintenance of wakefulness test. They're falling asleep in just 2 or 3 minutes. Remember how the maintenance of wakefulness test, you're asking somebody, stay awake for 40 minutes in a comfy chair in a dimly lit room, and you got to do that 40-minute test 4 times across the day. And so here's the test times at 10, noon, 2 p.m., 4 p.m. And the type 1 narcolepsy patients are just terrible at this. And they treated them daily for 7 days. And even on day 7, the placebo patients are still staying awake for less than 5 minutes. But what you can see is that the patients who got the medium and the high doses did spectacularly well on the maintenance of wakefulness test. 40 minutes is the best you can possibly do. And so the high dose on both day 1 and day 7, they were basically staying awake for the full 40 minutes. And the lower dose, you see more intermediate responses. And it's interesting that on the first day, you get this really strong response with the medium dose, and then it's still good. It's still better than the other meds that we have currently, but it's also, you can see how variable it is and how it's not quite as potent as it was on the first day. In type 2 narcolepsy, the placebo-treated patients had somewhat longer baseline or placebo latencies of 5 to 7 minutes. But again, the low and the high doses were also effective. But the variability here is huge just because the number of subjects is rather small. And also the maintenance of wakefulness test is kind of prone towards noisiness, I think. Also, I want to point out that the doses are higher here. So here, the medium dose was 44 and the high dose was 112. And the feeling is that type 1 patients may be especially sensitive to orexin agonists, so that they respond to lower doses. And I think that's kind of clear from the responses in these two groups. Okay, it also improves subjective sleepiness. So in type 1 narcolepsy, these patients showed, with the low dose, an 8-minute reduction in Epworth and an 18-minute reduction with the higher dose, which is really incredible because, they're starting with Epworths of about 18 or so. And so essentially it's getting them down to an Epworth of nearly 0. In the type 2 patients, you also see pretty nice improvements. And again, I just want to point out that the magnitude of improvement in Epworth that you see here is really substantial. The cataplexy wasn't a primary endpoint in these experiments, but they just sort of compared it to the cataplexy rate in the week prior to this inpatient study with the infusions. And so patients had 2 to 6 episodes of cataplexy over the prior week, but none of the NT1 patients had any cataplexy during these infusions. So Takeda has sort of made the most clinical progress, but this company called Alkermes, which is just based outside of Boston, has a drug called 2680, which also looks pretty good. So they showed this data at the World Sleep Meeting last fall. And so again, they're doing the maintenance of wakefulness test. And this is a study focused on just NT1. And this is, I want to point out, really early data. This is a phase 1 study of just 4 subjects with NT1. And they studied them with a variety of doses. So they recorded them on 1 day with, I think, probably with no dosing. And you can see, again, very short latencies on MWT of less than 5 minutes. And then the gray is placebo on the treatment day. And you can see the response across the day here. And so this is hours. And so I'm pretty sure that these are the test points 2, 4, 6, and 8 are the MWT test times. But then they added a 5th one late in the day. But I think the idea is the drug is worn off at that point. And so then you have these doses ranging from 1, 3 to 8 milligrams. And basically with the 1 and 3 milligrams, with the 1 milligram, you're getting sort of intermediate MWT latencies in the sort of 20 to 30 minute range, which is still pretty respectable, but starting to fade a little bit later in the day. And with the higher doses of 3 and 8, it's again pegged at 40 minutes, the best you could possibly do. And the medium dose seems to start fading a bit on the last test session, and then as the drug wears off later in the day. But pretty good looking for an oral once-a-day drug. So the drug that proceeded the furthest in clinical development is TAK-994. And this is another very well-characterized drug. You can see the structure there. When it's given to C57, so these are wild-type normal mice, you see these dose-dependent increases in wakefulness, but when you give it to the orexin 2 knockout mice, it doesn't do anything. And here's the calcium mobilization, same thing as I showed before, where it activates calcium mobilization. The orexin ataxin 3 mice are a narcolepsy model. And again, you can see increases in wakefulness at very low doses in those animals. There was a really great New England Journal paper with Yves Dauvier as the lead author last fall. It's a phase 2 study of a pretty solid number of people treated with TAK-994. And these are just type 1 narcolepsy patients. And people were treated for 2 months with the drug. And so they were assigned to different groups: placebo, 30, 90, or 180 milligrams twice daily. And the sleep latencies on maintenance of wakefulness tests were typically dreadful in the placebo group of 4 minutes. But they're 30 minutes at the low dose, 35 minutes at the medium, and basically 40 minutes at the highest dose. And I want to point out that the normal MW, well, actually, first, we don't have a great data on what healthy normals just off the street do on a maintenance of wakefulness test. but their sleep latencies are probably in the 30 to 35-minute range. And so 40 minutes is spectacular, but it may be more than, it may be kind of super physiologic. It may be more than really is needed. So anyway, even the low dose here looked pretty good. 30 minutes, substantially better than anything that we currently have available. The Epworth scores went from 14 at baseline down to 5 to 3.5 to 1. So every treated group is in the normal range. And their weekly cataplexy rate went from 10 episodes a week down to just 1. So looks great in terms of efficacy. Sadly, TAK-994 was stopped in its development because of an unfortunate and unanticipated side effect, which was some elevation of liver function tests. And so this is showing the safety evaluation. And I wanted to, sorry, this is just so busy, and I hope you guys can see it. But when you have any sort of new class of drugs, you've got to be braced for potentially new and weird AEs. And so there's a couple of things that show up here, which we don't generally see with anything else that we use to improve wakefulness. And so people got some urinary urgency and urinary frequency and salivary hypersecretion. And these are, I mean, it's like, where does this come from? I think it's just, this is part of exploring a new class of drugs. You know, the orexin neurons do innervate places that are relevant to urination and salivation. So sure, maybe it has to do with that. But what's interesting is it shows up quite consistently with this drug and with pretty much all the orexin agonists that have been developed. So increased, probably it's more of a urinary urgency like you get with caffeine. I don't think there's an increase in urine production, but we don't really know that yet. But anyway, people found it to be kind of a nuisance, but almost nobody has stopped any of the clinical studies because they're bothered by the urinary symptoms. And so you can see that these are also dose dependent, and they show up a little bit in the extension trial too, where people were kept on the same dose. The thing that was bad was that about a handful of patients developed elevations of their liver function tests. And for some, it took months for them to normalize. And it really was kind of worrisome. One person even had an elevation of their bilirubin. We don't fully understand what this is about, but the general feeling is it's probably not a class effect of the orexin agonists. It probably has something to do with some peculiarity of the structure of this TAK-994. And so the development of that drug has been stopped, which was really a disappointment because patients were really looking forward to this moving ahead. But there's other drugs in the pipeline. So I want to just step away from narcolepsy for a second. Emmanuel Mignot had a paper last year with, again, a small study of patients with idiopathic hypersomnia. So this is just 12 people. And in this case, it's that drug I told you about before, the TAK-925, which is the intravenous one. And so they get the infusion across the day, and they're given either placebo or the high dose of danuvorexon, 112 milligrams. And so you can see that on the maintenance wakefulness test, they were averaging sleep latencies of about 10 minutes, and that went up to 40 minutes with this infusion. And again, I would emphasize that this is probably overshooting. You don't need to get to a 40-minute latency. But what's cool about this is it does suggest that orexin agonists can be beneficial in people who have disorders other than type 1 narcolepsy. The question is, again, the balance of efficacy and safety. And again, these folks had the same issues of urination and dizziness or runny nose. So I want to just finish up in the next few slides on some kind of complicated mouse experiments that we've done, because we were sort of, as I showed you this slide before, orexins act in a lot of different brain regions. And then the slide doesn't even show it, but like, for instance, orexin neurons directly innervate the cortex. They innervate the basal forebrain, which is crucial for activating the cortex. But which of these are really important? And so we wanted to ask, what are the crucial pathways in the brain through which these drugs are really having their effect? And so bear with me to just show you something from my lab on how that question can be answered. And so we started off first by making a new narcoleptic mouse model. And this is where we basically put the human diphtheria toxin receptor after the orexin promoter. And so if you inject these mice with diphtheria toxin, it selectively kills the orexin neurons. And so in this bottom left panel here, you can see wild type mice treated with diphtheria toxin have a normal number, about 1,200 orexin neurons. If you take this particular line of mice, these DTR mice, with the receptor and give them saline, it's the same. But if you treat them with diphtheria toxin at 1 week and 3 weeks, there's like a 99% loss of these cells. It produces a very thorough loss of the cells, and it's selective. It doesn't kill other cells in the same general area. These mice, as you can imagine, rapidly develop narcolepsy. And so there's tons of data on these slides, and I'm just going to point out a few things. I hope you guys can see my cursor. Let me just get the laser thing here. Oops, no, that's for drawing. Oh, I don't see the laser. Anyway, I'll just point with the cursor. But basically, if you look at the duration of wake bouts, this is focused on the dark period when the mice are active. Normally at baseline, their wake bouts on average, before the orexin neurons are lost, their wake bouts are about 10 minutes long. But 1 week and thereafter, so here's the time points. We studied the mice at 1 week, 3, 6, and 9 weeks. Their wake bouts are now only about 2 minutes long. So they can't maintain wake anymore. And over the subsequent weeks, you can see the number of cataplexy bouts increases. And so it doesn't happen immediately. There's something that changes in the brain over time where the cataplexy emerges. But it's very acute sudden orexin neuron loss. So we then treated these mice with a tool compound. It's another orexin agonist called OX201. I'm not going to show you the preclinical characterization, but it's a good selective OX2 agonist. You can see here that it helps produce really long wake bouts. It completely reduces the amount of cataplexy in a dose-dependent way. And so it's very effective in this narcoleptic mouse model. Sorry, I didn't want to leave time for questions, and so I'm zipping through this kind of quickly. What we then did is we took this mouse, this orexin diphtheria toxin receptor mouse, we crossed it with another mouse that we've made where these mice lack the orexin 2 receptor. We put this transcriptional blocking sequence, this disruptor sequence TD, between the first exons of the orexin 2 receptors. And so these mice are born with no functioning orexin 2 receptors. But this little disruptor sequence is flanked by what are called LOXP sites. And so we can inject something called adeno-associated viral vector that codes for CRE into the brain. And the local cells will express CRE, and that CRE enzyme will cut out this little sequence, and those cells will now make OX2 if they were meant to in the first place. And so it's a way of focally restoring OX2 signaling, but only in certain parts of the brain. And so we have a narcoleptic mouse lacking orexin neurons, born with no OX2 receptors, but we can pop them into certain brain regions. And so what we can then do is we can say, let's put the OX2 receptors into the tuberomammillary region where the histamine neurons are and ask, does the drug work if you only have OX2 in this part of the brain, but nowhere else? And what you can see here is that, so we study the mice at baseline, we give them vehicle or we give them the agonist. And what you can see is that the amount of wakefulness increases when we give them the drug. The wake bouts get longer, but there's no change in the amount of cataplexy. And so having orexin receptors in this part of the brain is sufficient for this orexin agonist to promote wakefulness, but it doesn't, this site doesn't regulate cataplexy. We've also done the same thing in the basal forebrain. It looks very similar to this, so I just didn't bother putting in a slide. In contrast, if we go down to the midbrain and we put orexin receptors into the periaqueductal gray, so here's the aqueduct, and you put it into this ventrolateral part of the periaqueductal gray. If we then give the mice the agonist, you see a tiny increase in wakefulness, but the wake bouts are still really pretty short. But the amount of cataplexy is substantially reduced by the drug, as shown in the blue bars. And so what's cool here is that we're not having really any significant effect on wakefulness when you have OX2 only in this brain region, but it is a sufficient location for the drug to suppress cataplexy. And so the way that we look at this now is that we now have evidence that the orexin 2 agonists can work through the tuberomammillary nucleus region or the basal forebrain to help improve the maintenance of wakefulness. And then they can work through these midbrain regions, this ventrolateral periaqueductal gray, to suppress cataplexy. I didn't mention it, but there's a whole literature on why this region is important for triggering this. So these experiments show that OX2 signaling through these regions is sufficient to improve these endpoints, but there's probably other brain regions. It's just that these are at least a minimal list of routes through which an OX2 agonist can work. All right, so sorry for the really dense neurobiology at the end there, but But I look forward to the questions. And just to zip over the main things that we've discussed, we talked about how the current meds we have for narcolepsy are pretty good, but there's still room for improvement. Patients have a lot of concerns still. And I showed you some data on how these orexin 2 receptor agonists can really produce large improvements in sleepiness and cataplexy in narcolepsy type 1 patients. But there's also some very early data on how they may also be effective in type 2 narcolepsy and idiopathic hypersomnia. And then the last bits there were about the routes through which this works, where the agonist can promote wake through the tuberomammillary region or basal forebrain, or can suppress cataplexy through this periaqueductal gray. So thanks very much for your attention, and sorry for going right up to the last minute here, but I will be happy to take questions at this point.
Thank you, Tom. I'll give a minute for questions to trickle in here to the chat, or people can unmute to get things started. So I noticed that, you know, what you highlighted from the New England Journal article about the Takeda product with the LFT abnormalities, that seemed like that was mainly with the higher doses, but you also pointed out that even lower doses, particularly for type 1 narcoleptics, seem to have pretty robust response. Do you think that they were throwing the baby out with the bathwater a little bit as far as a potential target at a lower dose still?
Yeah, I think from a FDA approval perspective, if you've got some of your patients developing pretty bad liver inflammation, it kind of kills the whole program. But in hindsight, one could imagine it's like, oh, if they had never tested the high doses in the first place, maybe it might have worked well. Because even though, as you say, even the low dose worked really nicely, and the low dose was not hepatotoxic in the same way. Having said that, however, you know, we don't fully understand the mechanism of this LFT abnormality. And, you know, it's possible that even at a low dose, there may be some smaller number of people where the LFTs could have been a concern. I think we don't really know the answer to that.
Looks like Chris Cano's added a question to the chat here. Hey, Tom, great talk. There's thought to be little to no orexin in the periphery, but there is thought that orexin receptors might be expressed in the gonad's bone marrow. Any concern about long-term effects of these drugs in the periphery, given that these are given orally?
Yeah, no, I think that's a very legit concern. And there's really very little research on the effects of orexin receptors in the periphery. Now, admittedly, you know, there's not a heck of a lot of orexin receptors in the periphery, but it does kind of raise the question of, might there be, just in the same way that you get the increased urinary frequency, might there be other sort of weird AEs that we should be looking for? And so I don't, you know, it'll be an interesting question to see what if the FDA sort of drills into that and says, all right, you don't show, you know, normally we wouldn't ask for this, but, you know, they might want to sort of throw up a few more safety endpoints. I think I saw Robert with his hand up.
Yeah, I don't know if he just got kicked out.
Okay.
Or
So
not.
there's a
Robert,
question from William Rodriguez of narcolepsy in Hispanics. Wow, I wish there was more to say on that. I mean, this is sort of, you know, setting the meds aside. That population has not been studied in any sort of specific way. Emmanuel Mignot, about 20 years ago, had a nice paper where they looked at the symptoms of narcolepsy across various groups. And they've also subsequently published a couple of papers on narcolepsy in African Americans specifically. For instance, like the whole HLA association is a little bit different in African Americans. Symptom presentation can be a little bit different. I cannot off the top of my head recall specific things about Hispanics, except I would say that for anybody who comes from sort of a disadvantaged community, you know, for narcolepsy in general, there's already a big delay in diagnosis. It takes people 5 to 8 years to actually get their narcolepsy diagnosis. And you can imagine for some people coming from these other groups where they don't have such great access, it may be even longer.
Tom, would you say that it seems like most of the ones coming down the pathway now or are orally and not IV?
Yeah. So that IV drug, the TAC-925, is a really good drug. It works really well, and it's kind of neat to think about how you might be able to play around with it intravenously. It's just it's not gonna. It's just for reasons. You can't take it orally. It just doesn't get to the brain sufficiently. And so I think all the companies that are working on this are really hoping to make a pill. You know, I mean, but it's an interesting question. I have to say, in the early days, we were kind of wondering if TAC 925 might be used, like, like in the same way people have an insulin pump. Maybe you could dial up your TAC 925 dose, in the same way that people make fine adjustments to their insulin. But as best I understand, there's no particular plans in development for bringing 925 to narcolepsy patients, but they may develop it for other things. Oh,
Uh,
Dana. So, Dana, do you just want to unmute? I think you should be able to talk.
Yeah, can you hear me?
Yep.
I was just wondering if there's an upcoming role for studying the orexin drugs and severe sleepiness related to depression.
Yeah, it's a good question. Dana is one of our sleep fellows, and in our clinic, we see an ample number of these patients who come in with feelings of just crushing tiredness, and we often sort of feel like, might this be sleepiness due to a psychiatric disorder? And sometimes they say, I don't really feel that depressed, and yet, they get on a different antidepressant, and suddenly their sleepiness clears up along with their mood. And so it's often hard to untangle these things. And I say this comes up pretty frequently when we're talking about patients who carry possible diagnoses of IH and NT2. I guess, Dana, the very fact that orexin agonists are beneficial in NT2 and IH makes me think they're probably going to be good for sleepiness of multiple causes. And so I suspect that it may be beneficial, but would it work directly as an antidepressant as well? I'm not sure. It's possible. And so it'll be interesting to see if at some point somebody actually does a study really focused on that group, because there's certainly plenty of people out there where they're depressed and sleepiness is a substantial concern. Yeah, I mean, it's interesting because, psychiatrists use wake-promoting medicines pretty frequently in this population already, right? They're using amphetamines and modafinil and so forth.
Thank you.
Dr. Scammell, thank you for taking the time. I'm conscious of the fact that we're a couple minutes over now. So unless there's any burning questions, perhaps we can break.
Right. Thank you very much, everybody, for listening and for the good questions. Bye-bye now.